Hello everyone, welcome to our Thursday webinar series. My name is Lourdes and I am happy to be with you all today. I'm going to just wait a few minutes while everyone gets connected and situated on the webinar. As a reminder, patients and caregivers, anyone who is watching can put questions into the Q&A or the chat box. Please remember to make sure that your questions are general in nature, as we can't answer specific questions. And I'm happy to introduce Dr. Philip Garfin. He is a Senior Medical Director in Clinical Research and Development at Jazz Pharmaceuticals. He's a board-certified pediatric hematology, oncology, and stem cell transplantation physician, and Dr. Garfin has led industry-sponsored clinical trials for approximately 10 years, including his time spent as an academic researcher and physician. Dr. Garfin has worked in all stages of drug development from discovery through drug approval. Thank you, Dr. Garfin, for being here with us today.
Great. Thank you, Lourdes, for the introduction, and thank you to the Cholangiocarcinoma Foundation for the opportunity to present this webinar. As Lourdes said, I am an oncologist, although a pediatric oncologist. I have been working in adult cancers, including biliary tract cancer, for several years now, and I've had the opportunity to work with the wonderful people at CCF for the last couple of years. I was going to be joined today by my colleague, who you may have seen on the flyer, Dr. Jim Harding from Memorial Sloan Kettering Cancer Institute. Unfortunately, he is taken ill and won't be able to join us today, so I will try to do his part of the presentation justice. I am happy to try to answer questions at the end. Probably flows better if we wait till the end. I will not be able to read the chat as we go along. And as Lourdes mentioned, I cannot give specific medical advice on this call, but I can give some general descriptions of the disease and a clinical trial that we are excited to have open in the United States. With that, I will move in with a quick highlight of what I wanted to discuss today. I first wanted to introduce everyone to a protein that is known as the HER2 protein, and then discuss its role, or what we think its role is, in biliary tract cancers and in the treatment of biliary tract cancers. We'll segue then into an overview of drug development and clinical trials, and finish with a description of a molecule that we are testing in a phase 3 clinical trial known as Zanidatamab, and talk about that trial as hopefully information that is helpful to people on this call. Just so you know who you are hearing from first, I do work at Jazz Pharmaceuticals. This is a global biopharmaceutical company, and we work in particular on hard to treat and less common diseases. We are more than 3,000 people, I think closer to 4,000 now, so a small to mid-sized biopharmaceutical. And we focus on two main areas, oncology and neuroscience. I'm on the oncology side of the program. So before we get into the cancer and cancer treatment too much, I would first like to introduce everyone to HER2. So what is HER2? HER2 is a protein that is in and spans across the membrane of cells, as shown here in this figure on the right. The little sort of maroon balls with pegs on them sort of look like old binder clips. Those are supposed to represent the cell membrane going across. And there are regions both inside the cell, which is to the bottom, and outside of the cell. The outside of the cell portion of this molecule or protein will bind signals from the body. And when that binds, it's like a light switch, and it turns on the activity in the inner part around where those A's are. Don't worry specifically what those A's are. They're just active domains of the protein, active regions, and they can send signals into the cell. These signals often can be many things, but usually include telling the cell to survive, telling the cell to grow, or telling the cell to multiply. So it's a growth signal. And that's partly why this molecule is called HER2. HER2 stands for Human Epidermal Growth Factor Receptor. Don't have to remember all of that, other than it's the growth factor is things, a signal that makes it grow, and it's the human version of it. It's called this because it looked like another protein they found earlier, the growth factor receptor 1. It also has a few other names that you may have heard or may come across. They do describe the same thing. One of these is NEU, N-E-U. Sometimes it's called HER2-NEU, sometimes it's called NEU. This is because around the time this protein was being discovered, it was also being studied in neurons. Sometimes it's also called ERB-B2, which is more usually referring to the DNA part that makes the HER2 protein, but sometimes you will see either HER2, NEU, or ERB-B2 in some product or treatment descriptions. HER2 is expressed in many places in the human body. It's expressed in early growth, but also in adults. It's found in multiple parts of the body. The places where it's most commonly seen are sort of illustrated on this figure on the right-hand side of the slide here, left-hand side of the slide. The highest parts, or the areas where the most HER2 can be found normally, are in the heart and the lungs and the skin. It's also found in the digestive system, so your stomach and intestines, and can also be found in the liver and gallbladder. This is important to know when we come back to how we've seen this molecule look in people when we talk about it. I'll come back to that in a minute. HER2 has been shown since about the early 80s to play a potential role in many types of cancers. Too much HER2 can lead to too much of these growth and survival signals, such that the body can't control it, and you can have tissue growth, cells growing, and that's where your tumors can come from. In a normal cell, as we can see illustrated in this darker gray, there are usually 2 copies of the HER2 gene, or ERB-B2 DNA, with a varying number of receptors on the cell surface, or these HER2 proteins sticking in and outside of the cell. In cells that have a change or a mutation that leads to overexpression, there are a couple of things that can happen. One is you can have something known as gene amplification, where instead of there being 2 copies of the DNA for the HER2 gene, there are multiple copies, sometimes 4, sometimes 6, sometimes odd numbers. And if you have too much of that gene, you can make too much of the protein. You can also make too much protein without having that amplification or increase in copy numbers, so that you get a lot of extra HER2 receptor on the cell. These lead again to too much of the on-switch activity, so too much growth of cells, too much survival, too much division. And this can drive cancers to grow and cancers to spread. In some cancers, HER2 is known to affect survival and patient outcome. It is most well known in the treatment of breast cancer, where patients who had HER2 positive disease, or those cancers that have extra HER2 protein in them, their survival was much shorter than those who did not have HER2 on their extra HER2 on their cells, on their cancer cells. That is sort of shown in this graph here on the right, where at the top left is time 0, so time of diagnosis of the cancer or starting for the treatment. The one at the top means that 100% of the patients being studied in this trial were alive at that time. If a patient unfortunately perished or was no longer able to be followed because of they moved or withdrew permission, etc., this line can drop. And so the lower the line goes represents fewer people alive with the cancer at the time. The red line is HER2 positive. It's about 1/10 of the patients in this study. But you can see this line falls down much more quickly than those patients whose tumor did not have HER2, extra HER2 on it. This is an area of intense study in biliary tract cancer, what the effect HER2 might have on the outcomes. It is not known yet, but people such as Dr. Harding, who wasn't able to join us, are looking very actively at the sorts of thing. One of the things that this protein has done, however, because it sticks out of the cell and it has a signaling mechanism, cancer researchers and treating physicians have been able to target the HER2 protein to treat the cancer, manage the growth, and slow it down. One of the first ways that was published in 2005 is with an antibody known as trastuzumab, or marketed under the commercial name Herceptin, which you may or may not have seen ads for. When patients have a cancer, a breast cancer that's found to have HER2 overexpression on it, they can receive trastuzumab or similar molecules, and this actually leads to improvement in survival for these patients. In this, which is a very similar graph to the other, where it just uses 100s as opposed to ones, so percentage as opposed to proportion, these are all patients who had breast cancer that was known to have HER2 positive status. And before the effects of trastuzumab were known, they had to test it and see how well it worked. In the patients who did not receive trastuzumab, you can see this relatively steep decrease over a few years in survival. The patients who did receive trastuzumab in this study managed to survive, many of them managed to survive longer, showing that trastuzumab can be a very effective treatment in this disease. HER2 treatment has also been shown to be effective in other diseases, such as gastroesophageal adenocarcinoma, so stomach and throat cancers, the swallowing tube cancers, and in other cancers as well. We are still looking at it in biliary tract cancers. In biliary tract cancer, HER2 is found in about 20%, or 1 in 5 patients with biliary tract cancer will have elevated HER2 levels or have HER2 positive status. It's a little bit different depending on the major anatomical subclasses of biliary tract cancer. So for patients who have intrahepatic cholangiocarcinoma, or ICCA, it is relatively uncommon to find HER2 overexpression there. Less than about 5% of those will have HER2 overexpression. But there are other targetable mutations that are found in a higher prevalence or higher occurring rate in ICCA, such as FGFR2 fusions and IDH mutations, for which there are a couple of treatments in later line therapy available. Patients with extrahepatic and parahilar cholangiocarcinoma are more likely than those with intrahepatic cholangiocarcinoma to have HER2 positive disease. 15 to 25% of these tumors will have HER2 overexpression, as well as other mutations as well, although it hasn't been fully studied when, how they go together and not. And patients with gallbladder cancer are typically the most likely to be found to have HER2 positive, with 20 to 25% of the samples having it. The sort of simple way to remember it is the farther you get from the liver, the more likely there is to be HER2 overexpression. Doesn't mean that there is none in the intrahepatic cancers or that all of the ones outside have it. It's just sort of a general rule of thumb. There's a lot of words on this slide, but I just wanted to include this one to show that there have been several different attempts so far with varying degrees of success, although mostly promising, to use HER2 as a target for treating patients with biliary tract cancer, with HER2 positive biliary tract cancer. You'll remember the antibody or treatment I mentioned before, trastuzumab or Herceptin. Sometimes people give this with chemotherapy. It adds the HER2 blocking activity of trastuzumab along with the cancer killing activities of the chemotherapy. There's not too many big studies about this, but it is something that doctors will use sometimes. There's a second antibody that targets the HER2 protein. It sticks onto a different part of the HER2 protein, also outside of the cell, and it's called pertuzumab. So there was a study that was published multiple years ago with a combination of trastuzumab plus pertuzumab, and this had good enough anti-tumor activity that this is used by many practitioners for patients with HER2 positive biliary tract cancer. These next two are a little bit different approach. They start with trastuzumab, again, this protein or antibody that binds outside of the cell, and these things that end in nib, like tucatinib or lapatinib, and there are others with the sort of nib. That nib it's an inhibitor. So in the outer portion of the cell, the antibody binds. In the intracellular portion, of HER2, where those little A's were, these proteins that end in Nib, that's where they bind. And they prevent, even though the switch might be turned on the receptor, they prevent the signal from getting to the cell and making it grow, or getting farther into the cell and making it grow. Trastuzumab deruxtecan is another agent that is out there and more recently of interest in the biliary tract cancer space. It is what is known as an antibody drug conjugate. So it starts with the same antibody, and I'll show a picture of an antibody in a minute. Starts with the same trastuzumab antibody, and then it's got a little linker molecule, which then sticks a chemotherapy to the antibody. So the antibody will bind the HER2 on the cell, and then will release the chemotherapy to kill that cell. So you can get chemotherapy more directly to the cancer cell rather than giving it to the entire body. This allows you to give sometimes more potent chemotherapies that might be too powerful to give to the regular, give in the body, or sometimes it gives you ones that are very specific and don't travel well in the body. Trastuzumab deruxtecan has recently had an FDA approval for patients with HER2 positive cancers that have already received treatment and don't have other available treatments. This does include biliary tract cancer, but is not a specific FDA approval for biliary tract cancer. And then the last one on this page, not just alphabetically, but also the one that I'll talk about, is Zanidatamab. And this is a unique antibody that actually binds two different HER2 molecules at the same time. This is what I work on, in full disclosure. And we have applied to the FDA for approval to have this approved for clinical use, both the FDA in the US and in Europe as well. So I wanted to then move in to what is Zanidatamab and how would we use it in the treatment of biliary tract cancer. And this includes a study that Dr. Harding and others were big contributors for. So some of you may have seen pictures of antibodies before. It's okay if you haven't. If you have seen these schematic drawings of antibodies before, you might recognize that Zanidatamab, which is in that gray box on the right, looks a little different. On the far left is a typical therapeutic antibody, schematic drawing, of course, where these blue and pink parts bind to the protein on a cell or on whatever you want it to bind to, so they just stick to it. And they can block it or they can do other things. This sort of grayish blue part then is a handle that the rest of the immune system can use to come recognize where the antibody is stuck and deal with it, clean it up, remove it, kill it. It's used a lot of times in this pathway for treating, when your body has a bacterial or fungal infection, you'll make a lot of antibodies that, or viral infection, that will go use these mechanisms to contain that illness. In a typical antibody, the part of the antibody that binds the target it's called a variable domain, not critical to remember, but it's got a very stereotyped appearance and looks the same across many different antibodies, or very similar. There are smaller engineered variants like we use in Zanidatamab that change the geometry and the binding a bit. So in this case, we have the smaller version here, the engineered fragment binds location 1, and the normal fragment binds location 2, and the handle still recognizes the rest of the immune system. So how does that look, at least schematically? These long wiggly things are just a different representation of the HER2 molecule, like in the beginning. The Zanidatamab binds two different molecules and cross-links them, we call it, or it binds in trans, across. So it binds across the molecules, with one part binding to the domain or the region of the protein that is called number 2, and the other that is region number 4. And because these are different regions, you can imagine then you could put another Zanidatamab molecule here on region 2, which could stick to yet another region 4 of another HER2, and you can build a long chain of HER2 Zanidatamab, HER2 Zanidatamab, HER2 Zanidatamab, and get a big clump or chain of proteins. This leads to several ways that Zanidatamab can help attack the cancer. There's a lot of different graphics on here. And I've labeled the basic activity down in the bottom just so that there are some major takeaways. So yes, this picture is not quite accurate. It's a little different than the previous ones. Sorry about that. But anyway, when Zanidatamab binds to a HER2 molecule, normally on the left here, this is the active HER2 sending the signal into the cell. Zanidatamab prevents that activation signal from even getting into the cell. You can't activate HER2 if you have Zanidatamab binding there. If you build these chains like I've mentioned, you could. Interestingly, it's not just like 1 + 1 + 1 + 1. It's more powerful than that in blocking the signaling. And our scientists have shown that in laboratory conditions. So both of those stop growth signals and survival signals from the existing HER2 molecule. Another activity that Zanidatamab leads is it can lead to the cell creating little bubbles and internalizing or taking in the HER2 and the antibody because it no longer looks right to the cell. It's out there, these complexes. That leads to the HER2 being broken down and not being available on the cell surface anymore. So it removes even the light switch that could be turned on to let the signal go. So you have decreased opportunity for HER2 signaling. And then that sort of handle part also is useful, at least in our model systems in the laboratory, and it's a little harder to show that these things are happening in a clinical trial. But in our laboratory systems, this handle part does get recognized by the rest of the immune system, and it activates 3 mechanisms for the immune system. All of them lead to removal of the cancer cells from the body. The first, and you don't need to remember these names, but in case you hear people talking about them, to give you an idea, the first is called antibody-dependent cellular cytotoxicity. So basically that means the antibody is stuck on the cell. Another cell that has the ability to kill cells recognizes the antibody on the cancer cell, and then this immune cell kills the cancer cell. These are the CD8 cells that you may have heard about in other contexts and often get talked about in things like discussions of HIV or other viral illnesses. And that's called ADCC for short. There's another one, ADCP, very similar, antibody-dependent cellular phagocytosis. A phage is something that eats in Greek. And so in this case, instead of the CD8 cell or the killer cell coming and killing the cancer cell, a big cell that can eat and break down other cells comes and it eats the cell. So it's a cell-dependent eating of the cancer cell. And the last one is called CDC, or complement-dependent cytotoxicity. Complement there's a system called the complement system as part of your immune system. Bunch of little proteins come and stick on the antibody and lead to a variety of things, such as punching holes in the cell membrane, attracting killer cells, or attracting phagocytotic cells. So there's 3 big mechanisms in here, which is stopping the cancer signaling, preventing or removing the ability to signal, and turning on the immune system against the cancer are the big ways that Zanidatamab works. Again, these have all been shown in detail in laboratory systems, sorry about that, and to a lesser degree where we are able to in samples from patients. So with that little background of Zanidatamab, we did try Zanidatamab in several different studies so far that include patients with biliary tract cancer. The first study was something called our phase 1 study, where we wanted to detect, 1, if Zanidatamab could be safe to give to people, and 2, at what dose, and thirdly, does it work in different kinds of cancer? In that study, which is not shown here, but I can provide more details on later if people want, we did show that Zanidatamab is safe to give at a variety of doses, and it did have activity against multiple tumor types, including biliary tract cancer, where slightly more than 35% of the patients with biliary tract cancers had a disease response, had their cancer respond well to treatment. That activity that we saw, along with the safety, led us to develop a focused, specific study looking at Zanidatamab in biliary tract cancer. This is called the Horizon BTC-01 study, also known as the ZW25203 study. In this, patients with HER2, too much HER2 in their biliary tract cancer cells received Zanidatamab every 15 days, or 14 days, I'm sorry, in a 28-day cycle. The cycles are more for record keeping and other activities. They basically just got Zanidatamab by IV every 2 weeks. We did divide these patients into two groups of patients because the first thing we looked at was the DNA copy number, so if you had extra DNA copies, you were eligible. If you had a lot of protein on the cell surface, then the patient could go to cohort 1, which was our first cohort of interest. If there was less, patients went into cohort 2, which was more exploratory because we didn't know if it would work. Zanidatamab would work in this population. We continued to follow these patients, not only to see how their tumors responded, but how long it responded. Was this safe to continue giving long term? How long did patients survive? We also asked the patients along the way how they were feeling, and we did some biologic studies. It occurred in several countries, including Canada, United States, Chile and South America, France, Italy, Spain, the United Kingdom, China, and South Korea. We found at the end of this study that of the 80 patients we were looking at for activity, 33 or 41%, so 4 in 10 or 2 in 5 patients had their tumor shrink by 30% or more of its original size, which is the criteria that we use in clinical trials for partial response or complete response. 2 patients of these 33, in fact, had their tumors go completely away and we couldn't see them anywhere. Doesn't mean they're absolutely gone. It just means we couldn't see them with standard X-rays, etc. About another third, 28%, had their tumors shrink by less than 30%, but not grow more than 20% from the original size. And we call that stable disease. That's here in blue. And the remaining third, the tumors grew for those patients more than 30%, or progressive disease. Overall, 54 of 80 patients, 68%, had their tumors shrink at least some degree, even if it didn't reach that 30% threshold. We also found that patients could survive or have a little bit better longer-term outcomes than if they just received the standard treatment for this disease. The standard treatment is chemotherapy. For all patients with biliary tract cancer, chemotherapy who've received prior treatment, chemotherapy provides a progression-free survival, so that's time without your disease getting worse, of about 4 months. With this, the median progression-free survival was closer to 6 months, 5.5 months. Patients who did have a response, so those patients that were in the green bar before, had a duration of response of almost 15 months. In all patients, when you look at standard chemotherapy, overall survival for patients is unfortunately about 6 months. We know it's a very challenging disease. For patients with HER2 positive disease who received Zanidatamab, the overall survival, median overall survival is about 15.5 months. So a big improvement over the 6 months. This medication does have some adverse events or side effects that can happen with it. The spellings for these are in British English for whatever reason, they just are. The most common is diarrhea. We grade adverse events on a scale from 0, there is none, through 5, which means it's so bad that someone dies from it. But there's 1, 2, 3, 4 along the way. So 1 and 2 are less serious. And most patients who had diarrhea had grade 1 or grade 2 diarrhea. There was only 2, grade 3 or 4. Most of the diarrhea was managed just with Imodium, or the generic name loperamide. And almost everybody, all except for 1, were able to manage their diarrhea at home, didn't have to go to the hospital. People also had infusion-related reactions. These tend to occur while the antibody is going into your body through the IV. This happens with almost all big protein molecules, and can be managed by things like Benadryl, Tylenol, and steroids. The other ones that were seen in several people, irritation in their liver, blood counts were somewhat decreased, abdominal pain, nausea, fatigue. But almost all of these adverse events were in the grade 1 or grade 2 category. There were grade 3 events. There was only 2 patients who had to stop their treatment for adverse events, and both of those after being on treatment for many, many cycles. And there were no deaths due to Zanidatamab. So it was in general something that patients could tolerate with help from their doctors and their supportive, their supporting cast. And hopefully we're also getting benefits from it as well. So that was sort of the summary, a quick overview of the big study that we did that we applied to FDA for. Promising activity, hopefully manageable safety for most people. And so it inspired this trial we'll do next. Quickly, I wanted to just give a brief overview of drug development, just for orientation and grounding purposes, because while it's something that I deal with every day, I know most people, thankfully, don't have to deal with it every day. When we're discovering a drug, there's a lot of work that goes on in the laboratory and in laboratory sciences and engineers and things like that to understand the drug, to test it in other model ways to see if it has activity, what it could be toxic for. If you determine from all of those activities, which are very closely scrutinized and looked at by regulators, that it might be safe to go into people in a clinical trial, you enter in a phase 1 trial. The primary goal for phase 1 trials is to understand the dose and overall safety. Phase 2 and phase 3 tend to be bigger trials, always looking at safety. Safety is always of very important concern, but also is there activity, and what is the best way to provide this potential new drug to patients in a trial so that you can create a meaningful benefit. We need clinical trials to answer these questions so we can know what is best for patients, what works, what is safe, and how to give it. A trial is not just a company or a group of individuals deciding to do something. There is lots of scrutiny from regulators, review panels at universities. This includes, the review panels often include not just university employees, but members of the community, or there are independent of these review boards that also review too. So we try to make this as the most appropriate trial as we can, and one that is acceptable to the most number of people. And there are international guidelines on rights and patient protections, et cetera. There are 3 things we try to do in a trial, which is minimize bias, which means, we're not letting people do what they want. You try to standardize things so you can really understand. We need to know how the study was done and be able to communicate it, so everything is protocoled in very much detail. And some studies, especially phase 3s, need a control group, which is people who are getting standard of care treatment or maybe a placebo, to see if the new drug actually leads to an improvement or it's just sort of the same thing. Each clinical trial should have a primary objective or overarching question. For example, does Zanidatamab, will giving Zanidatamab to patients with HER2 positive biliary tract cancer, will it be an improvement over what patients are receiving now? Things should be stated in advance so you're not fudging the numbers at the end by changing the question in the most technical terms. And it needs to be clinically relevant and measurable. So we need to be able to say, yes, it's improved by this much, but it can't just be numbers. There's got to be some improvement, something you can say is actually benefiting the patients or people in the study. At Jazz, we work with lots of people to try to develop these trials and make them available to people. This includes, many trained physicians in the field, as well as trained sort of general clinical trialists, advocacy groups such as the Cholangiocarcinoma Foundation and equivalents in other countries, and having advisory boards with patients, treating physicians. This means that we present our information or we present our study designs and we get feedback from the general population to try to see, is this going to work for patients trying to enter into the trial? And is this the best way we can test the drug? Development does take a lot of time. I think you've probably heard this in lots of the general news articles about drug pricing and things like that. And unfortunately, yes, there's other issues around that, which I won't talk about today. But it is a long, slow process. A new medicine can take 10, 15, even longer years from concept to completion. Most drugs do not actually get all the way to completion, we'll call it. And in a disease like biliary tract cancer, it's important to get as much information as you can from any one trial because we don't have that many opportunities to learn and improve outcomes for patients. Just a general plug on how do you find clinical trials. Your doctor is your best source usually, but your doctor isn't necessarily aware of everything. Support groups such as CCF have a great website, which, and I keep plugging the sponsors here, but it's deservedly so, have a great website with lots of information about trials. There are also things from like the National Institutes of Health or equivalents around the world, like clinicaltrials.gov, where you can search for a specific disease or condition, and it can point you to potential trials and potential sites, things that you could bring to your doctor or your support organization to find out more. Before you join into a trial and participate in a trial, a very important step that should be administered at every trial for a situation like longer-term cancer treatment at any center around the world is an informed consent process. So you should have a discussion with your treating team about what the trial involves, the activities, the risks, your rights, and potential benefits from this trial. And you actively need to agree to participate in the trial, and as follows. So I wanted to move in the last couple of minutes to a description of this trial. This is the slide that I show when I'm trying to give everyone all of the details of all of the treatments and everything, and I'm certainly happy to come back to it, but I think it's a little easier, even for me who sits and thinks about the trial all the time, is rather than having all of the details in the boxes, what are the points of the boxes? So the dark blue boxes are the primary study activities, or the things that we expect to go on as part of the study. The green and light blue boxes are, before and after the study, and the rows are some general features about the study. I'll start with the general features about the study. This study is known as the Horizon BTC-02 study, or JZP598302. Horizon BTC-02 is probably easier to remember. It will include patients who have biliary tract cancers, not including cancers of the ampulla of Vater, so iCCA, ECCA, and gallbladder cancer. It's for patients whose disease is HER2 positive, and patients that have not received treatment in the locally advanced or metastatic setting. So patients who can have their tumors completely cut out are not for this trial. Patients who have received chemotherapy for tumors that can't be cut out are also not for this trial. This trial will enroll about 300 people in 24 countries. It is open at a handful of sites in the United States, and we are opening more. And there's a couple of drugs on here, pembrolizumab and durvalumab, that have entered the treatment space for biliary tract cancer in this first-line setting. And these are given in the trial if it's allowed in the region. So in the United States, patients, both are approved, so patients can receive pembrolizumab or durvalumab as part of their standard of care. If they don't want to, or there's a reason to not get it, you don't have to either. So how do we determine who comes on the study? Patients are referred to the study through a variety of mechanisms. If patients are in potential patients, their disease is stable, their health condition is well, relatively well, they can wait a couple of weeks before starting chemotherapy or other treatments. Then a tissue sample is sent to a central laboratory so that all of the reads from all around the world are identical to see if the tumor is HER2 positive. If the tumor is HER2 positive, we'll use the other information about your disease, such as where it is, how large the tumors are, is it affecting any of your other organs, to determine if you meet the criteria to join the study. They're pretty general standard criteria for an oncology study, cancer study. If you're able to join based on that, eligible to study, a patient will have an unbiased it's done in a random fashion by a computer, not by a person, and I don't know what the outcomes are, assignment to a treatment arm. And I'll explain the treatment arms in a minute. I wanted to go back because not every patient who comes to this trial or comes to their eventual treating oncologist, knows that they're having this disease in the very beginning, or not all can wait for treatment. Some patients will need to start treatment more quickly than others, or the place where a patient first goes doesn't have the trial open, and you get referred to another center, sort of like from a smaller hospital to Jim Jim, again, who's not here, Memorial Sloan Kettering, which is a very big, very dedicated cancer center. So patients do have the ability in this trial to have received some chemotherapy prior to enrolling in the trial. It has to be the standard of care treatment that you would get in this trial, which is the standard of care treatment in the United States. So gemcitabine, cisplatin, with or without the pembrolizumab or durvalumab. You can receive up to 2 cycles of that while all of these things are in process and still be able to enter the study. In the same way, patients would be assigned to, in an unbiased fashion, to a treatment arm, where either they'll continue their standard of care therapy, so the trial takes away nothing from patients, they still will get their full therapy, or they get their standard of care therapy plus Zanidatamab, the antibody we just talked about. Patients will have their disease evaluated a little more frequently than you might in a regular clinical practice, but that's often the case with clinical trials because you need to have a precise measurement. And we'll continue to follow you for as long as patients allow, or as long as survive. The things that we want to know is how long do patients with HER2, really strong HER2, or the 3+, which is the highest strong disease, how well do these patients respond to treatment and how long do they continue to benefit? We'll also try to find out how long these patients live overall, as well as then all patients with HER2 positive, which is 2+ in our code language for it, or 3+. We also look very closely at safety and your loved one's reports of how they're doing, their benefit, quality of life, their activity levels, etc., as well as biology on the study. As I mentioned, the study is open or is planned to open in 24 countries, just listed here alphabetically. It is open in the United States, and I was focusing on the United States. For here, this is not all of the sites yet in the United States. These are sites that are actively opening and ongoing, and they will continue to be updated in places like clinicaltrials.gov or the CCF link to the clinicaltrials.gov as we open more. We are in particular trying to open some over here in this part of the country, but otherwise we do have sites ranging from Puerto Rico to Seattle and easy for me to say, the Northeast and the Heartland as well. I know I've been speaking for an hour, almost 45 minutes. I want to thank you for your attention. I want to thank you for your interest in this. And I want to thank CCF for the opportunity, and I wish you and your loved ones all the best in your courses. I am happy to take questions.
Thank you so much. That was really informative. If anyone has questions, please feel free to enter them into the chat or the Q&A. I know we had a couple that came through. Have you seen any difference in efficacy of Zanidatamab in different types of biliary cancer? Like, is it better for extrahepatic or intrahepatic disease?
We did look at that in this trial. Sorry, and I'm skipping through it, and I didn't show it here. We did look at it in this trial. There was no statistical difference between any of the 3 anatomic regions. I stated statistical because that's the best way we can report it, whether or not there was something we couldn't measure with the numbers. I can't say, but statistically they were equivalent, or all the same.
Okay. Do we have any understanding if Zanidatamab might be valuable for those who have already been on HER2 therapy?
So that is a question we are trying to understand. In this trial that I'm showing here, this Horizon BTC-01, patients could not have received prior HER2 targeted therapy, so we don't have the big number for that. We do have, however, in our phase 1, there were 5 of the 22 patients did receive prior trastuzumab, and there's only 5 patients, so we can't make general claims, but there were patients who did have cancer respond to Zanidatamab in that group after receiving prior trastuzumab. So we don't know the extent, but it is a possibility, so we can say.
Okay. Will crossover be allowed for patients who progress on the standard of care?
So in the, I'm presuming this is in the phase 3 trial, we are hopeful that this study, results of this study that's up here, will gain approval by the FDA in this calendar year. And if that becomes the case, then crossover wouldn't be needed because Zanidatamab would be available as a monotherapy. And it's not clear necessarily that continuing, we haven't studied if continuing the other treatments and adding Zanidatamab on later would have any other benefit. But so we are hopeful and doing everything we can to hope that it's available either through commercial, regular pharmacy supply, or through expanded access or patient support programs, should there be appropriate approvals.
Okay. Are participants excluded from a trial if they have had a side effect while on the first or second line treatments, for example, the development of a blood clot?
So that depends on specifics. Certain things like blood clots, if it resolves or is managed without complications, that would not be a exclusion. That would not take a patient off the trial. There are other things that are less common, like inflammation of the lungs, or changes to heart function that don't recover, which are also less common, which may require a patient to come off of Zanidatamab therapy. But if they're still receiving pembrolizumab or durvalumab, depending on the kind of event, they may be able to continue those on trial.
Okay.
I don't know if that helped.
Could you say a little bit more about the immune component of Zanidatamab? Is this a checkpoint inhibitor?
That is an excellent question. It is not a checkpoint inhibitor specifically. It is, so this activity, the immune activity shown on the right, the ADCC and ADCP components are actually seen with many antibody therapeutics, antibody-based therapeutics, so it's not unique to Zanidatamab. While it helps attract and turn on the immune system, it doesn't overcome those checkpoints that are being referred to. However, we do think that with the pembrolizumab or durvalumab, those two potent checkpoint inhibitors, either one of those, will overcome the blockade and allow the immune system to turn on better in response to Zanidatamab.
Okay, thank you. Is Zanidatamab currently available on expanded access or compassionate use basis?
There are expanded access and compassionate use programs available in the US and multiple other countries. The best way to make use of those, there's a request that your physician can make from the Jazz website, or if your physician has a question on how to do it, we can have local members of the Jazz team help as well.
Okay. Will the FDA approval of Zanidatamab enable addition of this to the standard of care as first-line therapy?
So the current study, I'm skipping too far. This study that is what is applied for, we've applied the FDA for, is for Zanidatamab monotherapy, so Zanidatamab alone, in replacing or postponing the standard of care therapy for second line. So if this is approved, patients could have Zanidatamab and then receive the chemotherapy that they would receive after it, not at the same time. This study, which will take several years to complete and get the answers from, the goal of this study is so that, yes, it ends up becoming standard of care, includes Zanidatamab. That's if the study is obviously meets its endpoints, is safe, is recommended by the panels of experts, etc.
Okay. Would Zanidatamab work on lung nodules for that is like HER2 with the same HER2?
We have seen So if it's a primary biliary tract cancer that has
Yes.
spread to the lungs or other parts of the body, it does work on those sites. The only part we are not sure about and have not really studied is brain. Biliary tract cancer doesn't often go to the brain, but other cancers do. And it's the type of molecule doesn't get into the brain space very well. But lung, liver, peritoneum, which is like the lining of your stomach, muscles, lymph nodes, patients have had tumor in all of those and have had response to Zanidatamab treatment.
Okay. Those are all the questions that I see that have come in. If anyone else has any questions, please add them now to the Q&A or chat. I suppose I have a question. If Zanidatamab and this clinical trial, is it open, or would there be consideration to include patients who might be under the age of 18?
So right now, patients for this trial have to be 18 or the legal age of consent in their countries. We've looked into the opportunity or need in younger patients, and HER2 positive biliary tract cancer doesn't really happen in children and young adults. That's not to say biliary tract cancer doesn't, but HER2 positive doesn't, that we found.
Could you compare Zanidatamab to I'm guessing they're mentioning trastuzumab, maybe TUC/TRAS broadly?
Oh, yeah, so that's tucatinib and trastuzumab. So tucatinib and trastuzumab, I can't really do a direct comparison because there's trials for both Zanidatamab and tucatinib and trastuzumab. They have slightly different patient populations and analyses and things like that. It would be possible to do a direct head-to-head trial at some point, if that would help patients, figuring out the order. Both Zanidatamab and trastuzumab tucatinib have been presented at major conferences and both show anti-tumor activity. Both are promising for patients with many HER2 positive diseases. Personally, my biased preference, well, I won't say, but I told you which one I work on. But I think I don't want to downplay the other agents. They have potential as well.
Okay. Will patients in the phase 3 trial know whether they are receiving Zanidatamab?
Oh, yes. I forgot to mention, this is an open label trial, so you will know what you are receiving. The only people, myself and my study team, will be blinded to the results of your scans. So we don't do any unintentional influence on our sites or anything. So I won't know what's going on with patients, but the patients will know, and they'll know what they're receiving. And there's no placebo control in the other. It's just standard of care.
Okay. We just had a couple of questions regarding whether or not someone knows whether they're HER2 positive. So for those of you who are wondering about that, you would ask your physician for biomarker testing to get that report and see if your tumor is HER2 positive. That should show up on those reports.
Yeah, and HER2 reporting on the what tests available in the US is becoming more common. It is not necessarily in the front page of the report because we don't have specifically approved agents for it yet, although that is coming in a standard of care at most institutions, because we do have other agents for other targets. If this trial is willing to do the screening as well, but it's in an investigational use only assay, which means it has to be associated with the trial, and can't really be used, although it's not relevant, I guess, to be used for other treatment. But if you wanted to find out, there is we call it pre-screening, where you can just have your sample sent without any of the other information and things like that. It needs your consent, of course. You need to. We don't need to collect all the other information. Your doctor would have to coordinate with a trial center, but that information can be provided to your doctor as well on who to coordinate.
Okay. Is a biopsy needed to screen for HER2, or is there a liquid biopsy test?
Unfortunately, at this time, we still need to do a biopsy. One of the things that we would like to develop with information from this trial is liquid or less invasive ways of detecting HER2 to save patients from having to go through biopsies.
Great, thank you. I don't see any other questions. And I know we appreciate your time and the information that you're sharing. And I know that the community also appreciates the information. So thank you so much for doing this and sharing about this.
Well, thank you, everyone. And again, best wishes to everybody who's going through this.
Thank you. Everyone, we hope you have a great afternoon.